acute rheumatic fever. And of course, like I say, your learning outcome is your best friend. Okay, you need to be able to answer these learning outcomes before you even think about entering the exam hall. Ini tak lepas, tak payah fikirlah masuk exam hall, okay? Faham tak? You have to be able to answer these learning outcomes, baru you should feel confident about answering your exam questions. So also, something to note is that you haven't heard, have you, in general pathology, have you heard terms like etiology? Dah kan? Okay, so all of these terms you will hear again and again in pathology. Okay, so etiology. What's etiology? The cause, right? Pathogenesis?
Process of pathology.
The mechanism. Okay, pathogenesis, pathophysiology is the mechanism. How does the how does that injurious agent cause the disease? Okay, it's the mechanism, it's how. Okay, and then from the how, you will get clinical features, because it's from the pathogenesis that will give rise to the clinical features. Betul? Like in infection, you get a fever, right? How do you get a fever? The clinical feature is a fever, but how do you get the fever?
Pathogenesis. Inflammation response.
Inflammation, right? You have cytokines. The cytokines are released in response to inflammation, and it causes vasodilatation, and therefore it increases your body temperature, right? So you have the etiology, you have the pathogenesis, and then you have the clinical features, right? And then, because we're doing pathology, of course, we want to see with our eyes how it affects the body. So we look deep into the tissues, we look at the cells, right? So that's the pathology. So the microscopic features, the gross features, right? And then sequelae. What's sequelae?
Prognosis.
The consequences. What happens next? Okay? It's different from effects and complications, because we're talking about the lesion itself, like the lesion lah, the sequelae of the lesion itself. So macam kalau thrombosis, the sequelae is what? Resolution, propagation, embolism, right? Emboli, so that's sequelae. But then the effects and complications of that, like if it embolizes, what do you get? What's the complication? Pulmonary embolism. Okay, so that's effect and complications. Okay, so these are terms that you must be familiar with, because you're going to see it over and over again in every single lecture. Okay, so make sure you understand what they mean, because nanti dalam exam kita tanya, what is the pathogenesis of so and so? List 5 clinical features of so and so. Okay, so if you break it down like that, it will be quite simple lah for you to understand and study. Okay, so in different systems, there will be in different diseases lah, I would say, there are diagnostic criteria, because as a doctor, when we want to diagnose a patient, your patient is not going to come with all the features like in the textbooks. Okay, it's not going to come with all the complete features. If it does come like that, as doctors, we get very excited. Yeah. Very lame kan? Macam benda macam tu, kita get excited. But it's true. If the patient comes in typical, with all the typical symptoms, all the clinical features, it ticks all the boxes, we get very, very excited. Because most of the time, they don't come like that. They don't come, dia macam the disease tak baca buku lah. Dia tak adalah macam revise dulu, oh aku kena macam ni, patient macam ni, okay. Faham tak? Like they don't come typically. So what clinicians do is we have diagnostic criteria, so that okay lah, kalau dia fulfill 2 out of 3 criteria, boleh lah, kita boleh panggil this disease. So that applies in a lot of different diseases. So similarly in acute rheumatic fever, it also we also use diagnostic criteria to diagnose the patient. Okay, so the name of the diagnostic criteria we will go and learn in a bit. Okay, so like I said, learning outcome, best friend, huh? Okay, so what is rheumatic fever? Have you heard the term rheumatism before? Rheumatism. What's rheumatism?
Autoimmune. Autoimmune.
Autoimmune. Okay. So you're talking about rheumatoid disease. Okay. So rheumatoid disease is an autoimmune disease, but what does the term rheumatic? Rheumatic. Have you heard of the term rheumatic?
Inflammation.
Inflammation of. Okay,
Joint.
so rheuma, I think, is joints. Okay, so actually, rheumatic fever is inflammation of the joints. So what does joints have to do with the heart? I thought kita dah masuk cardiovascular system. Kenapa doktor cakap pasal joints pula ni? Why are we talking about the joints? Because it's the inflammation that occurs in the heart, yes, but actually it affects your joints, and patients commonly present to you with joint pain. Okay, so clinically it's more of a joint problem, so we call it acute rheumatic fever. But the reason why I'm talking about it in cardiovascular system is because it affects the heart quite a bit, and it can go on to cause chronic problems in the heart. Okay? So it's an acute rheumatic fever is an acute autoimmune multi-system inflammatory disease. Okay? So it's not just the joints and the heart, it can also affect the brains, it can also affect your skin, your subcutaneous tissue. Okay, so it's multi-system. Okay, and it's the offending agent is a bacteria called Group A Streptococcus pyogenes. Okay, the name of the scientific name is Streptococcus pyogenes, but it's under the umbrella term of Group A strep lah. And this Group A strep, it causes a pharyngitis. Okay, so the typical scenario is a little child, maybe about 10 years old. She had a pharyngitis or inflammation of the throat maybe 2-3 weeks ago, and then she presents to you 3 weeks after that throat infection with joint pain and fever. Okay, so the initial infection is a throat infection. Okay, 2-3 weeks later she will present balik with joint pain and fever. The throat infection dah resolve dah, tak ada masalah dah, but she comes back to you 2-3 weeks later with joint pain and fever. Okay, so that's the typical scenario. Okay, so what happens? So you have a Group A Streptococcus pharyngitis, and the body will react to the bacteria, right? Betul? Okay, so there is a particular antigen on this Streptococcus called M protein, which is particularly pathogenic. What does that mean?
Can cause a disease.
It's pathogenic, means it can cause disease lah. And it's very antigenic in the sense that the body really recognizes it as foreign and mounts a response. How does the body mount a response to antigens usually?
Antibody.
It produces antibodies, right? Okay. So the body will produce the antibody, and usually they produce IgM, kan?
Yes.
In initial infection, in the acute infection, it will produce an IgM, and then after the IgM is produced, the body now makes IgG, right? And then the IgG and the lymphocytes, the plasma cells, will circulate in the body, and in case the Group A strep comes again, it already has memory cells to mount a response. Betul? Okay. So what happens is your initial infection has resolved. Okay? Your body has successfully mounted a response and cleared the infection. The body has made these antibodies, but the problem is these antibodies not only reacts to the M protein, now it also reacts to the body, to your own tissues. Okay? This usually occurs 2 to 4 weeks after the initial infection. Okay? And it, like I said, it affects your brain, it affects your joints, it affects your skin, multi-systemic, right? And this phenomenon is called molecular mimicry. Okay? where the cells or the antibodies recognizes the M protein on the bacteria, but also recognizes self-antigen, because the self-antigen or rather the M protein mimics the antigens on the body. Okay? Okay. So who is susceptible to it? Supper, like, I mean, you guys haven't heard of it before, so it mustn't be that famous. But obviously it's a problem because I'm teaching it. So who usually gets it? Okay, so the risk factors of acute rheumatic fever are patients who are of poor social economic background and who live in very cramped areas. Okay, and it mainly occurs in children. Okay, so acute rheumatic fever usually occurs in childhood, but it can occur in adulthood, but it's about 20% lah out of all the cases. So not very common in adults, more common in children. And the complications following that are also mainly affecting children. But it will spill over lah, because they will grow older and they become adults. So usually in the adulthood, baru we see the full-blown complications of chronic rheumatic disease or of this problem lah. Okay, so the peak incidence is 5 to 15 years old. Okay, so I said it affects your brain, it affects your skin, it affects your heart. So how it, the clinical manifestations, how it manifests is in the heart, it causes pancarditis. Pancarditis is inflammation of all the 3 layers of the heart. Okay, in the skin, it causes erythema marginatum. Okay, in the joints, the term is called migratory polyarthritis. In the subcutaneous tissue, it produces subcutaneous nodules. And then in the brain, when it affects the brain, the patients present with something called Sydenham's chorea. Okay, nanti I will go on to explain what they are. So all these clinical manifestations, they make up what is known as the Jones criteria. Okay, so just now I said, nak diagnose kena ada diagnostic criteria, right? So the name of the diagnostic criteria is called Jones criteria. Okay, or revised Jones criteria. Yeah, I explain a bit later. Okay, so what's pancarditis? So I said pancarditis is inflammation of all 3 layers of the heart, right? So your endocarditis can be inflamed, your myocarditis can be inflamed, and your pericarditis can be inflamed. Okay, if your endocarditis is inflamed, so endocarditis is the innermost layer, right? And it also bersambung dengan the valves. It's continuous with the valves, so it causes valvular damage. Okay, your myocarditis, when it's inflamed, this is the most common cause of death in patients with acute rheumatic fever. I mean, death isn't common in acute rheumatic fever because now in this day and age, it's quickly diagnosed and patients are given antibiotics quickly. But usually, if there is a death, it's caused by myocarditis. Okay, so inflammation of the muscle layer of the heart, because once it's inflamed, you can't contract. The heart cannot contract properly. Okay, and as you can imagine, that would lead to death. Pericarditis is the outermost layer of the heart, and if the pericarditis is inflamed, it causes pain, so chest pain, and when you auscultate, you can hear a friction rub. You can hear something rubbing against each other. Okay, you know what auscultate is, right? You use a stethoscope to listen to the chest. Okay, and this is because the parietal pericardium, the inflamed parietal pericardium, and the visceral pericardium rub against each other, so it causes friction sound lah. Okay. So a little bit more about inflammation of the myocardium, because this is the pathology bit. This is the bit where we come at you with difficult names and difficult terms that you now have to remember and hafal. And Dr. Adnan says, too bad, you just have to hafal. I can't help you there. Okay, so this is the bit where this is the pathology bit lah. Okay, so in rheumatic myocarditis, so this is inflammation of the myocardium. Typically, what we see, if the patient dies, because we're not going to cut open somebody who's still alive. If the patient dies and we do an autopsy and we look at the heart, in the heart tissue, the myocardial tissue, we can see Ashkoff bodies. Okay, Ashkoff bodies. And what are these Ashkoff bodies? These Ashkoff bodies are actually aggregates of activated macrophages. Okay, where have you heard that term before? Collection or aggregation of activated macrophages. Sorry?
Granuloma.
Granuloma, right? Granuloma is a collection or aggregate of activated macrophages. But what type of macrophage? What are they called?
Epithelioid.
Epithelioid macrophages, because they resemble epithelial cells. Okay? They are long and slender. Okay, but here in the Ashkoff body, technically it's a granuloma, technically, because it's a collection of macrophages. But here, instead of being epithelioid, they are plump. They are very big and plump. What's plump? The plump. Plump. Okay. So they are very they look big. Okay. They have a lot of cytoplasm, and then some of them even have characteristically caterpillar-like nuclei. Okay. So those cells, those single macrophages that look like caterpillar, or if we cut section, it looks like owl eyes. So they're very prominent nuclei. These are called Anischau cells. Okay? So Anischau cells are those typical looking caterpillar-like cells, which are basically macrophages. And all these macrophages, they make up the Ashkoff body. Okay? And as you know, in granuloma, you can have giant cells, right? So similarly, in an Ashkoff body, you can see a giant Anischau cell. Okay? Okay. So in a granuloma, you also have reactive lymphocytes. So similarly, in an Ashkoff body, it's comprised of plump activated macrophages, also known as Anischau cells, with lymphocytes surrounding it. Okay? And then typically they have fibrinoid necrosis. Have you heard that term before? Fibrinoid necrosis? Okay, so in granuloma of TB, what term is it called? What necrosis do you get? Caseous necrosis. So in an Ashkoff body, you get a fibrinoid necrosis. So fibrinoid necrosis is a type of necrosis that occurs when you have a antibody antigen reaction deposit in the blood vessels, and there's an accumulation of fibrin. Okay, so that's why it's called fibrinoid. Okay. So this is the bit where you have to hafal. Yep. Okay, so typically the inflammation of the myocardium is located in the interstitial connective tissue. Interstitial connective tissue of the pericardium, and it occurs perivascularly. So that's why you get that fibrinoid necrosis. Okay, perivascular means surrounding a vessel. Peri, surrounding, vascular vessel. So it occurs perivascularly, and it leads to this fibrinoid necrosis. Okay. So this is what it looks like. This is the Ashkoff body. Okay, so this large thing is an Ashkoff body, and you can see cells inside, within, and you see this squiggly nucleus here, like this, macam ni, right? And if we zoom in, you see Anischau cells. Okay, and so that was higher power, and if we go lower power, you can see multiple Ashkoff bodies. So they're quite well circumscribed, right? They're quite distinct, and they occur in the interstitium, so between the myocardial cells. Okay, interstitium. Okay, so that was in the myocardium. What about if we look at the endocardium? Okay, so inflammation of the endocardium and the valves, they are characterized by beady fibrinous vegetations. So beady means bead-like. Bead, you know, like what's a bead? You know what a bead is, right?
Money.
So they're vegetations. Vegetations is basically growth lah, or of a growth of a foreign element. Okay, so they grow along the valves, along the cusps of the valves. Okay, and these are known as verrucae. So can you see dia macam biji-biji along the valves, along the lines of the valvular closure? Okay, so this is basically where you have an inflammatory response. Betul tak? So the injurious agent attacks the endocardium and you'll get an inflammatory response. How do you think this will heal? How does the endocardium heal? By fibrosis, right? So it will lead to formation of fibrous tissue. Okay, and if this happens in the valves, okay, how do you think the valve shape will be after it repairs by fibrosis?
Abnormal.
It will be abnormal, right? It will be shortened. Kan? Sebab fibrosis usually causes contraction, right? And what's the valve supposed to do? Open and close, right? It's supposed to open to allow blood flow, close to stop blood flow. So what do you think if one valve is shortened? Will it stop the blood from flowing? No, right? So blood can flow back. So if a blood flows back, that's called regurgitation. The other thing that can happen is it can fibrose and it can fibrose close to each other. Okay? So what is that called? You know?
Stenosis.
Stenosis. Narrowing of the outlet is called stenosis. Okay? Okay. So that's how a patient presents. That's the clinical manifestation of the heart in acute rheumatic fever. Okay? So like I said just now, it's a multi-system disease. Besides the heart, it can also affect other things. So commonly, patient presents, like I said just now, patient presents with joint pain. So the scientific or the medical term is called migratory polyarthritis. Okay, migratory means it moves. Poly means multiple. Arthritis means inflammation of the joints. Okay, so this is the most common manifestation of acute rheumatic fever. So patients will come to you complaining of joint pain and fever. Kan? Tadi I cakap the typical scenario. But it's temporary. The inflammation of the joints is temporary, most likely because of deposition of what do you call it? Antibody antigen complex, or the antibody actually recognizes a antigen on the tissue of the joints and causes inflammation, but it's very transient, sekejap, okay, and it resolves. Okay, so patients will present with swelling and pain of the joints. And typically it starts in the lower limbs and it migrates upwards. So that's why it's called migratory polyarthritis. Okay? Nothing special. It's just basically a fancy term for joint swelling. Okay. So if it attacks the subcutaneous tissue, the patients present with subcutaneous nodules. And what they are they basically firm lumps of collagen underneath the skin. That's all it is. Okay, and it usually appears in your extensor surfaces. So the back of your elbow, the back of your wrist, on your knees. Okay, where you place pressure lah, usually. Okay, and it's painless. It's absolutely painless. Okay. Oh, it was right. Okay, sorry. Oh, I haven't got anything, sorry. Today my daughter looked at my slides and Mama, the picture is too big, do you want me to fix it for you? I'm like, no, it's fine. I totally ignored her. She was right. I stand corrected, I'm sorry. Okay, so the fourth one is erythema marginatum. Okay, and then basically when the presentation is on the skin, It's a ring-like or snake-like or serpiginous, which is snake. It's a rash, it's a macular rash, a red rash, and centrally it has a clearing, so it's clear. The redness is only like a ring or like a snake outside, and it commonly appears on the arms and the trunk on your body. Okay? And finally, the fifth manifestation is Sydenham's chorea. This is when the antibody attacks your basal ganglia, and they present with involuntary, rapid, jerky movements, like they're dancing, sort of. Okay, and it typically occurs, or it typically presents much later than the other clinical manifestations. This one typically presents 4 to 6 weeks after you've had that pharyngitis. Okay? Okay. So how do you diagnose acute rheumatic fever? So the revised Jones criteria says that you have to have 2 major criteria, or 1 major plus 2 minor criteria, and you have to have evidence of group A strep infection. Okay? So that means tak sewinang-winang je lah orang yang datang dengan a history of throat infection 2 weeks ago comes to you with joint pain. You can't say, oh, ini definitely acute rheumatic fever ni. Tak boleh. So you have to fulfill the criteria first. Okay, so what is the major criteria? What is the minor criteria? And what is the evidence of group A strep infection? So tadi I said the major criteria is your 5 clinical manifestations. What are they?
Join.
What was the first one I said? Carditis. Second one is?
Carditis.
Migratory polyarthritis. The third one is? Erythema marginatum. The fourth one is? Subcutaneous nodules. And the fifth one is?
Sydenham's chorea.
Okay, so if your patient comes with any of these 5, okay, so that's 1 major. Betul? So, Dr. Nala kata, the revised Jones says if patient comes with 1 criteria, they need 2 minor and evidence of a group A strep infection. Okay. If they come with a subcutaneous nodule and they come with pancreatitis, so that's 2 major. Do they need a minor criteria? No, but they still need evidence of group A strep infection. Okay. So this is a mnemonic that I found on osmosis. Use it if you like, if it works for you. There are other mnemonics out there. Another one I think is called CASES. C for carditis, A for arthritis, S for subcutaneous nodules, E for erythema marginatum, and S for Sydenham's chorea. So whichever works for you, as long as you remember. Okay, so that's the major criteria. And the minor criteria is patient has to have fever, arthralgia, and lab evidence of infection. So what's a lab evidence of infection? Have you heard of the term CRP and ESR?
Yes.
Yes, I expect you should have already learned that in year 2. Okay, year 2. Okay, what does CRP stand for? C-reactive protein, and it's an acute phase reactant, right? So it's usually raised when patient has an acute inflammation. And ESR, what's ESR?
Sedimentation rate.
Okay, you've done this before, right? Kan? Betul. Ada buat practical kan, physiology. ESR. Ada tak? Tak ada. Okay. But do you know what ESR is?
Yes.
What is it?
The sedimentation.
Erythroid sedimentation rate lah. Duh, it's there on the slide. So your CRP and ESR is raised. ESR is basically, okay, so when you have an infection, your body will produce lots of acute phase reactants, one of them being fibrinogen. Okay, so fibrinogen makes your blood constituent a bit thicker, so your erythrocytes sediment later. Okay, so ESR is basically when you spin the tube, and your cells will mend up because they're heavy, so they sediment, right? So if there's a lot of acute phase reactants, it sediments slower, so it prolongs your ESR. You with me? You look confused.
Yes, I'm really confused.
No? Did I say that wrong?
It's okay, doctor.
Okay, if I'm wrong, you can correct me. And then you have to have ECG changes, prolonged PR interval. So it signifies a first degree AV block. Okay? So you don't have to have all criteria. So maknanya if you have one major, you only need two minor. So if patients come with fever and raised CRP, that's already two minor. Okay? Okay. And then you have to have evidence of a previous group A strep infection. So have you guys learned how to diagnose group A strep? Not yet. Okay. So of course a positive culture. Okay, when you do a swab of the throat and you culture and it grows group A strep, that's obvious. That will be evidence of an infection. What you can do is also take the titer of antibodies. So your body will produce an anti-streptolysin antibody. Okay, and if the titer is raised, then that is also suggestive of an infection towards streptococcus. And you can have a history of scarlet fever. So scarlet fever, have you heard of the term scarlet fever? No? Scarlet fever is also a strep infection, but it manifests more as a skin manifestation. Okay? So other relevant investigations that one would do, but it's not part of the Jones criteria, is you would do a chest x-ray, because as you imagine, if the heart is inflamed, it will appear larger. So on your chest x-ray, you will see an enlarged heart. Okay? And of course, like I said, if your endocardium is inflamed, it will cause valvular problems, so you will do an echo. Okay, because echo basically assess blood flow. You will be able to tell if there is stenosis or there's regurgitation. Okay, so you do an echo to assess heart function. Okay, but they aren't part of the Jones criteria lah. But we do it to assess the severity of the patient's condition. Okay, so that's acute rheumatic fever. Okay, so I said that the reason why I'm teaching it in the cardiovascular system is because it tends to cause problems to the heart, which we've seen, right? Pericarditis. But more commonly, what happens is you can get chronic rheumatic disease. Okay, so how does that occur? Agak-agak. Prolonged, that's a good guess. What's any other guesses? Prolonged or repeated. Okay, so repeated infections causes the body to produce antibodies, and like I said, these antibodies not only attacks the bacteria, but it also attacks your tissues, right? So repeated infections causes a repeated exposure causes repeated attacks on the heart tissue primarily. Okay, and so it develops into chronic rheumatic heart disease. Okay, so basically, what is chronic rheumatic heart disease? It is a clinical manifestation of rheumatic heart disease that appears years or even decades after the initial episode of rheumatic fever. Okay? And it depends on which valves are involved. But most commonly, it affects your mitral valve, and most commonly, it causes mitral stenosis. Okay? So, patient gets a throat infection, 2 weeks later, gets acute rheumatic fever, years and years later, they develop chronic rheumatic heart disease. Okay? But not everybody who gets a strep throat will get acute rheumatic fever. Betul? And not everybody who gets acute rheumatic fever will develop chronic rheumatic heart disease. Okay? So the incidence is, I remember actually, that's something you have to look in the books. Okay, so what are the cardinal changes of mitral stenosis? Like I said, the valve that is commonly affected is your mitral valve. And what happens is because of the repeated fibrosis, they will cause a valvular thickening. Okay, the valves become very thick and it causes a fusion, commissural fusion. Commissural means basically when things come together. So the valves come together and they fuse and it causes stenosis. Okay? Besides that, it also kan tadi you nampak like it also it's along the cusps of the valves. It can affect the chordae tendineae as well, or the cords, and this also causes thickening, shortening of the cords. Okay? Okay. So when it develops mitral stenosis, okay, so the diffuse fibrous thickening along the mitral valve causes a typical appearance called the fish mouth or buttonhole stenosis. Nampak tak? Dia macam buttonhole, kancing baju, right? Or a fish mouth. It looks like a mouth of a fish. So this is a typical finding lah in in chronic rheumatic heart disease. Okay. And then if we look at the valves more closely, you will see neovascularization. Okay, so again, this is a chronic inflammatory response. Okay, because of repeated assaults to the valves, new blood vessels are made. So you can see neovascularization. And if you compare this cord and this cord, it looks a lot thicker, right? So you can get thickening of the chordae tendineae, like I said just now. Okay? So you can get mitral stenosis, you can get mitral regurg, but mitral stenosis is more common. And what are the complications of mitral stenosis? So if your heart valve is small, right? And you know the mitral valve is in between the atrium, the left atrium and the left ventricle. The left atrium, after prolonged stenosis, just because of the increased pressure, it can cause dilatation. Betul tak? Because there's back pressure into the atrium, right? And if you remember from your thrombosis and embolism, what causes a thrombosis? What is the three factors in the Virchow's triad? Abnormal blood flow, endothelial injury, hypercoagulation. Okay, so if you have a dilated left atrium, where will that sit in your Virchow's triad? Abnormal blood flow, right? So the patient is more susceptible to develop thrombosis inside the left atrium. Okay, so you can develop mural thrombi. Mural means wall. Okay, the wall of the left atrium. Okay, if the left atrium is dilated, it can probably affect your sinoatrial node, right? Because your sinoatrial node is at the top of your left atrium, and it will cause atrial fibrillation. Okay. Over time, it can cause congestive heart failure, and it can also cause pulmonary changes. Okay, so you'll learn heart failure, I think, in the next few lectures, so that will become clearer to you, the development of congestive heart failure and pulmonary problems. Okay, and then you also have an increased risk of infective endocarditis. Again, this is something that you will learn tomorrow, I think. No, tomorrow lecture infective endocarditis. No. Okay, you'll get a lecture on infective endocarditis. So these are the complications of mitral stenosis. Okay, so like I said, it can affect other valves, but the most common is the mitral valve, and most commonly mitral stenosis. It can also affect your aortic valves in 25% of the cases, and your tricuspid valves infrequently, and your pulmonary valves very, very rarely. Okay? Is that clear? And that is the end of my lecture. Any questions?